Good morning. I'd like to welcome everybody to this Saturday's monthly webinar from Vein and Lymphatic University. I'm Ruth Bush. I'm moderating on behalf of Dr. Sarah Oneida, who couldn't join us today. Today's topic will be recurrence or recurrent venous disease. First of all, I'd like to thank our generous sponsors, Boston Scientific and Medtronic, for their support of this EmPowHER Educational Venous Series. Before I introduce today's distinguished panel, we will hear from the leadership of Vein and Lymphatic University, Dr. Lowell Kabnick and Dr. Victor Kanata. Would you please play their videos? Well, that was Dr. Victor Kanata. Unfortunately, we couldn't hear his introduction. Do we have Dr. Kabnick's introduction?
Hello, everyone, and welcome to today's session. My name is Dr. Lowell Kabnick, and I'm the chairperson of Vein and Lymphatic University. VLU is a premier educational platform whose mission is to deliver groundbreaking, high-quality content utilizing the talents of a diverse global team of health experts focusing on venous and lymphatic disease and treatment for the medical community and its patients. The goal of VLU is to make a positive impact on the global medical community by accelerating venous and lymphatic education through highly accessible and interactive live webinars and lectures, informative videos, and other premium channels of community engagement with the aim of empowering, inspiring, and advancing understanding of venous and lymphatic disease and treatment. Our initial series is titled EmPowHER, which was developed by Ruth Bush, Sarah Oneida, and Leanne Alizio. This is a series of webinars crafted and directed by our women colleagues for all. On behalf of VLU's Executive Board, we thank you for joining us.
All right, great. Well, there was our leadership of Vein and Lymphatic University. I invite anyone who is listening to go to the website, veinuniversity.com. So today we have a very distinguished panel and I hope will generate a lively discussion. We first have Dr. Marianne de Maeseneer. She is in the Department of Dermatology at Erasmus Medical Center in Rotterdam, Netherlands. Marianne has retired from clinical work as of June 2017, but remains very well connected in phlebology in her section, as well as around the world. She has done significant research on the issue of recurrent venous disease as well as treatments, and this was the topic of her doctoral thesis, which she defended in 2005. And I am pleased to have her join us and look forward to hearing more about her research. We also have Dr. Claudine Desnos, who's a specialist in vascular medicine. She's the vice president and former president of the French Society of Phlebology, as well as a member of the scientific committee of the International Union of Phlebology, the UIP. She serves in many leadership positions across Europe and in France. And then we have Dr. Linda Antonucci, who is a member of the board of directors of the American Vein and Lymphatic Society and president and CEO of Linda Antonucci Veins. She's a nationally recognized and respected vascular ultrasound consultant, as well as speaker and educator. She's on the board of directors for the AVLS and has served as the ultrasound allied health section chair for the AVLS ultrasound section, as well as the American Venous Forum annual meeting. She is an ARDMS credentialed vascular and cardiac technologist with over 30 years of experience. So I welcome all of our panelists and again, look forward to a lively discussion. The goals of today, talking about recurrent venous disease, is mainly looking at the diagnostic approaches in recurrence. How do we approach this in our clinic with our patients, and tips and tricks with both examination and with duplex ultrasound? How does the assessment differ in the recurrent patient from a first-time patient, especially if it's someone who you did not do their initial procedures, and trying to figure out what has been done and what they now have problems with, different therapeutic and treatment approaches, and then follow up on these patients. So with that, I'd like to get started. I'm just going to, rather than show a picture of a leg with a bunch of varicose veins, I'm just going to describe a patient who we may all see in our clinic. A 65-year-old woman who comes in with symptomatic varicose veins on her right leg, diffuse ropey varicosities. She has ankle swelling. She has itching and scaly skin over the varicosities, as well as pain. She has had a deep venous thrombosis in the past, is not on any treatment for this, and states that she had a high ligation as well as some phlebectomies in the past. But that was many years ago. So why don't I just start with, this patient comes in with recurrent ropey varicosities. All you know is that she had a high ligation. How would you approach this patient? And I'll just go across my Zoom panel. Dr. Desnos, what would be some of the questions and some of the issues you would be looking at? And again, think of someone who has just come from either another country or another physician, and you really don't know what type of operation they've had done in the past.
So first, I would ask the patient what is her demand about the visit, what she wants to do, and you say that she's symptomatic. That's important, first thing. And also, I would ask some more information about her past history of thrombosis, because you don't say much thing about that. So, and also clinically, I would look at her leg and see what are the varicose veins which are visible. And that's important for the superficial vein examination, to start by the clinical visible veins and to go proximally and to see where they come from. Of course, we have to check the deep vein system, because she has had thrombosis, vein thrombosis before. And after that, depends on what we are going to find. Of course, probably she has a recurrence from the groin, because she has had a high ligation, but depends on what type of recurrence I will find. Maybe it's if the lymph node system is involved, probably I would need to make some treatment by foam sclerotherapy. If I can do laser, I will do laser, but it depends on the network. I will find a venous network that will be present.
Thank you. Marianne, what are your thoughts?
So I think indeed you always have to start listening to the patient carefully. What are the complaints? What is the intention why the patient came to see you? So you spoke about some skin changes and so on. So that is important. And of course, try to find out as much as possible about the history not only of the surgery, because the patient not always knows what has been done. But as Claudine pointed out already, a patient with a story of deep vein thrombosis, sometimes patients also come into your office and they speak about history of thrombosis or phlebitis, they often also say. And then you don't know, has this been a deep vein thrombosis? Has this been only a superficial vein thrombosis? So you have to ask them, have you been on anticoagulant treatment? You know, just to make up your mind, what has this patient gone through in the past? So then once you know enough information, also kind of estimate the impact on the quality of life of this patient, then you do the clinical examination standing, and then almost immediately you proceed to do the ultrasound, also in the standing position, to evaluate the superficial venous incompetence. So as Claudine said, you have to start also at the level of the visible veins. So in a normal ultrasound, we would always start systematically in the groin, look at the saphenofemoral junction, then go down and follow the course of the great saphenous vein and see how large it is. You measure the diameter and things like that. But so you do the whole examination, let's say from the groin down to the popliteal fossa and then to the varicose veins. But in case of recurrence, what is typical, that you also start at a level where there are visible veins, especially when there are visible and palpable veins above the knee, because then you pick these up and then you follow them and make your way upwards proximally, let's say, to find out where do these veins come from. Are they connected with a residual trunk? Is there a lymph node venous network, as Claudine commented on? And so what is the story, what is the situation at the saphenofemoral junction? Is there a proper recurrence there, or is it starting maybe with some pelvic incompetence? You end up, you know, high on the thigh, maybe in the vulvar area and so on. So that is a possibility that you have to take into account. So, and then the treatment we will discuss later on, I guess, but just the evaluation. So it goes like systematically going down the leg, but then also going up again, let's say, to make the whole picture complete. That's a good trick for recurrence.
So I think that's a very good point, is not to do it in the same manner. One of the before I ask you, Linda, is one of the issues that often comes up is patients use the term vein stripping to mean pretty much any operation they've ever had. And so I think one of the points to make also, especially for any younger members who may be or younger physicians who may be watching is to look at the leg and to look at where the scars are, because whether it's a phlebectomy or actual, what we would term a saphenous vein stripping, I think the word is used sort of as a catch-all term by the patients. But I like what you said, Marianne, about starting sort of in the middle and following the veins up and down. Linda, what is your approach when someone is sent to you for recurrence?
Okay, so first off, let me tell you, Ruth, I'm not a physician. So
yes,
as a physician, I just want to make that clear. So I'm going to come at this from the sonography point of view. And of course, in the US, most physicians don't scan themselves. So they're very dependent on us. And we are constantly trying to unearth the source of the reflux. That's our job. But I think that in the world of phlebology, we have to also be clinical investigators. We can't just look at this as we're doing an ultrasound. So I look at the patient standing, I look at the patient supine. As you mentioned, both physicians mentioned, they're often poor historians. So they may say they had one thing when they haven't had that. So, you really have to sort of put the clinical picture together for yourself based on a little bit of what they're telling you and a little bit of what you suspect really may have gone on. And then I would do a very systematic ultrasound in both the supine and standing position, full interrogation of the deep system. If the signals in the common femoral didn't correlate, I would send for, if they were asymmetric in any way, send for something pelvic because they did have a prior DVT. So you don't know if they have an iliac compression, possibly, but you don't know if they really had a DVT or just a small phlebitis, as Dr. de Maeseneer said. And then I would do a standing investigation with ultrasound. And I would first I'm a big fan of standardization. And as an ultrasound teacher, I try to teach the students to do something in the same order so they don't miss anything. So I would do a very standardized ultrasound scan, but then I would absolutely go to the varix and trace it back to try to find the source. And if they can't find the source, they can always just say they assume it's something pelvic. If they're going back and I tell them, you don't necessarily, if you don't do pelvic ultrasound, you may not know where the source is, but you would know it's pelvic. You might not know the exact leak point, but we can at least trigger the provider that it's something pelvic.
So Linda, how have findings on ultrasound changed in the last 2 decades with the introduction of endovenous thermal ablation? How has neovascularization or recanalization, has that changed any approach that you've taken to doing duplex ultrasounds for recurrence? Because sometimes I have found that maybe part of the saphenous vein recanalizes, and then you have a lot of varices. Sometimes none of it. Sometimes you have sort of a neo saphenous vein above the fascia.
Mm-hmm. So I would hone in on.
Can I just first interrupt because
yes,
you just to comment, when it's outside the fascia, you can't call it saphenous vein anymore. So it's always a tributary at that
tributary.
point.
Very good point.
And so we really have to stick to the proper definitions that the great saphenous vein, the small saphenous vein, they are, and the anterior accessory, they are in their saphenous eye, as we call it on the ultrasound. So they are in the fascia, so in the duplication of the fascia. And so that's very important that we distinguish tributaries from the trunks or residual trunks that we find in cases, or recanalized trunks that we find in cases of recurrence. I'm sorry to interrupt you.
Oh no, very good point. Thank you so much, Marianne. Thank you. Thank you.
Yes, and we need more use of proper terminology. We need more standardization. This has been a big problem in our field. Everyone just does the assessment the way they feel comfortable doing it. And we have to have a certain amount of structure, although we can't cookie cutter these type of patients. I agree. But I think we should focus on the inguinal area, on the saphenous tract. For recanalization, I would always look for the source of recanalization, probably mid-thigh perforating vein, a pelvic. Sometimes you'll see gonadal veins coming down and just attaching in at the mid-thigh or even lower, and they start boring their way into that saphenous vein that was has been treated, and they will recanalize. So I do a very systematic, with and without color, with Valsalva if necessary, peripheral augmentation, sometimes even just B-flow. I'm looking for a magged image with B-flow. But to answer your question, it has changed dramatically. The ultrasound exam has changed dramatically, and it should continue to change and refine.
What would your advice be to, say, someone like me who doesn't have a Linda or one of your trainees that I can call? For example, I'm in a place right now that doesn't have a vascular ultrasound tech. And with COVID, sending someone out into the community for an ultrasound takes months and months. So I tend to do a lot of them myself. What would be your advice?
Well, that's the first thing I would advise you to do. Pick up the probe yourself, because the person holding the probe has the power. There's a certain amount of information that transmits from your hand into your brain. I feel when I'm scanning, I can be teaching, but I'll have to grab the probe because I have to look at something myself. So I think holding the probe yourself, getting proficient in ultrasound is a wonderful starting point. I don't know if there's any other advice I could give you. Matching, if an ultrasound comes back and it doesn't match your clinical suspicions, then absolutely have a rescan, order a rescan.
Thank you.
In Europe, we are quite used to do the ultrasound ourselves, and we teach the trainees. So I was working as a vascular surgeon in a department of dermatology. So in the Netherlands, lots of dermatologists are doing veins. So I was teaching these trainees, and it is amazing how quickly they pick it up, because if you have, the anatomy in your mind, then it's not that complicated to get started. Of course, to do a proper ultrasound in a recurrent case is complicated indeed, and that's a step further, but to learn the basics is really very important. And as we do now all our procedures ultrasound guided, it's a bit weird for us to have somebody else do the ultrasound, although I respect Linda, of course, your great skill, and if you work in close collaboration with the surgeon, as I have been doing when I was working in Antwerp, where we had vascular techs, it is great. And I mean, they learn every day. You look at some difficult leg together, and you teach them, and so then the techs learn more and more. So that's good. But we think it's very important that the doctor, him or herself, can also do the ultrasound. Isn't it, Claudine? I'm sure you are convinced of
Yeah,
that.
of course, I totally agree. Of course, for us, it's almost incredible that you can't do your ultrasound examination yourself. In particular, for recurrences, it's impossible to manage correctly recurrent network, venous network, if you don't perform ultrasound examinations. For us, it's really amazing.
But of course, you are an angiologist, so that's
of course.
Well, that makes sense, because it's very hard sometimes if I do send people out into the community to get an ultrasound, and when I get it back, especially for recurrences, I will get back the reports that, there'll be a few pictures that really just show me some veins. And the reports are not using proper terminology, Linda. They're not using, every lab is an entity of itself. And usually I don't get nice diagrams like what probably you do with drawings on the legs of where the entry points are for the veins. So I find these patients very, very hard to treat. So Dr. Oneida had said for this patient that the ultrasound findings showed, and I'll put them here in the chat, neovascularization and recanalization of the distal. So neovascularization, I assume that would be up at the groin, and recanalization of the distal thigh saphenous vein extrafascial tributaries, and no evidence of deep venous thrombosis. So I'm assuming this case she gave is probably someone who originally had some post-thrombotic varicose veins and was treated. But I don't know that, but then comes back with ropey varicosities on the thigh, across the lower leg below the knee. Not really in what we would consider a true axial distribution. So I personally have, you have these patients who come in with these large ropey varicosities, and my question that are recurrent is, what do you do with the neovascularization up at the groin, at the saphenofemoral junction, if you have a few tributaries that you can see that are then connected to some of the thigh varicose veins, or ones that are on the medial thigh, regardless of whether the patient had a high ligation or they had endovenous ablation. How do you approach those? How do you approach the saphenofemoral junction on these patients? Do you just remove or inject the tributaries? How do you approach the thigh recurrent varicose veins? I'll let anyone answer.
Yeah, I can get started. It is a typical case after high ligation that you get neovascularization, which is far more common in comparative studies comparing surgery and, for instance, endovenous laser ablation. It is far more common to see neovascularization in the groin after surgery. It is a kind of signature of well-performed high ligation to have neovascularization, because it's by transecting the vein that new vessels can grow and connect. And so in your example, it's a bit a special story, because there is neovascularization, but apparently the proximal part of the great saphenous vein was not there anymore, and it connects then with the distal half, let's say, of the great saphenous vein in the thigh. If I got you right.
So yeah. So someone who had high ligation, maybe they had some thrombosis of the proximal GSV, and then lots of thigh tributaries that then empty down in.
So if the trunk from mid thigh, let's say, to below the knee has a diameter of 6, 7, 8 millimeter, I would for sure also approach that one, apart from approaching the neovascularization and the tributaries close to the groin. So what I would do in this kind of case is probably a combination of foam sclerotherapy up close to the groin, and then an endovenous, probably an endovenous thermal ablation of the residual trunk from let's say below the knee to mid thigh. If that is, if you can cannulate it, then that should be the preferred option. And then either phlebectomies or foam sclerotherapy for the other tributaries, depending on the preference of the patient. So that would be a combination. You can also combine it in one go, let's say by for instance, if you use a radiofrequency catheter to do the thermal ablation, then you can put the catheter in place up to mid-thigh, let's say, and then before you do the ablation, so after you have put your tumescent, then you can inject foam through the channel of the radiofrequency catheter, and then the foam also travels to the neovascular vessels. But you can also just puncture them directly. That's a bit depending on your personal experience. But this combined way of doing it through the lumen of the catheter is also something that can be easily done.
That is not something I have tried before, but that works fairly well on those long catheters. That's my brilliant tip that I'm getting from today.
Yeah, but what you have to take care of is that you have to keep the lumen open throughout your procedure. So if you introduce, so you do the puncture, you introduce the catheter through the sheath, you have to keep the lumen open. So just flush it from time to time with saline, And then you probably will just get stuck in the middle of the thigh because the catheter will not travel more upwards. So you check that with the ultrasound, and it's exactly where the where the tributaries join the trunk again. So then you put your tumescent and still some saline from time to time, and then you prepare your foam gently and inject it through the catheter, and then you check with the ultrasound where the foam is going. Of course, if the distance is very long, then the efficacy of the foam may get lost while it's traveling to the groin. So if there are lots of large tributaries there, it's better to do an extra injection of foam directly in a vein that you puncture. But that's really an interesting tip. And of course, what is very important in these cases is that you do not do any redo surgery. That's really, in our new guidelines of the SVS, we have just this as a negative recommendation, that no redo surgery, that you should not do. Try to do it endovenously and in combination with foam. That's very important.
Thank you. Thank you. Claudine, any
I agree with
you would have?
Marianne. I agree with Marianne. If the trunk is about 6 to 7 millimeter in diameter, I would, if possible, I would do a laser or maybe radio frequency, but for the trunk. But there is a reserve about the efficacy, as you say, Marianne. If it's the part is too long to reach the groin, it won't be very efficient. So I would prefer, for the groin, I would prefer direct injection of foam under ultrasound guidance, because it's a risky area for arterioles, and I will check with the ultrasound. It depends on the type of varicose vein. Sometimes they are well visible and you can inject them directly, but before, anyway, you have to check with the ultrasound to make sure that there's no arteriole in this area. And most of the time, in this case, there are varicose vein from the lymph node, and you cannot inject them if you have not, if you cannot use an ultrasound. Otherwise, I totally agree with Marianne.
Yeah, and the reason why this is because if you inject foam, it travels like 10 centimeter in the vein that you have injected. But then once further up, the more the foam has been in contact with the albumin of the blood, the more it is deactivated. So then you just may see on the ultrasound maybe still, your foam and the bubbles and so on, but it's not active anymore. So there is no interaction anymore between the vessel wall and this foam, which has no active product anymore, because the albumin of the blood is really the enemy of the foam, and it just neutralizes the action of the foam. And that's the reason why if the distance is longer, then you really have to do direct injections, especially with these lymph node venous networks. That is really not something easy, so you have to do that carefully.
So we do have a question from the audience. I just put it in the chat for the panelists. Someone wants to ask about recurrent symptomatic veins that recanalized with intraluminal webs, superficial venous thrombophlebitis, and an irregular lumen that is difficult to close with thermal technology. I assume the person asking means you can't get the catheter, through these veins, but is quite large. Will that work with foam? What are your concerns about, putting a large volume of foam in? I would also add to this question, do you worry about skin staining? Do you worry about microbubbles in the venous system? Do you compress with ultrasound at the groin. So why don't you talk a little bit about that once where you cannot get the a catheter through.
Claudine, you want to get started, or you want me to start?
I don't know. It depends on what you call large volumes and what is the diameter, what's the length of the vein to treat. We have no
Let maybe first speak about the cannulation problems. No, you may have these fibrotic strands inside the vein that has suffered from superficial vein thrombosis. We call it now like this, not thrombophlebitis, superficial vein thrombosis. I love to have the right terminology. If it is difficult to cannulate, sometimes you can just cannulate part of it, and then you may have an area where there is lots of scars and you really can't make your way, even with all the maneuvers. You know, there are certain tricks. If you are a bit experienced, you can sometimes travel along the fibrotic strands inside. But then you can also opt for a second puncture. So just do your more distal puncture, keep the guide wire there, and then you just skip the area where there is lots of scars, and then you puncture again proximally from there, and you do it in 2 parts. So you do the ablation, the thermal ablation, then in 2 pieces, let's say, which is absolutely feasible. So that's a trick if the cannulation is not easy. Of course, in certain cases you really can't get in. You try to evaluate that with the ultrasound before you start the procedure. Of course, you do your ultrasound to check what will be the potential difficulties. But sometimes it's you give it a go and it still works, and you do travel nicely even up to close to the groin. But sometimes you get stuck, and then you can opt for the second puncture. But if all that is not possible, then you have the question, and Claudine will answer that one, I think. If you have to inject foam, then it may be a large volume, but there probably is lots of scar, so which means that there is lots of collagen inside this vein, and so whatever treatment you do there will be less efficacious than if you have just a naked, let's say, vein, a new vein to treat. Isn't it, Claudine?
Yes, probably. Yes, I think you're right, but sometimes we don't have any choice. You can do only foam, so you do it, and after that, it depends on the. I say that it depends on what you call large volumes. Most of the time, it's not so huge your volume, because if you inject even 7.5 ml of foam, it's not so huge, and most of the time it's enough. You have to start with a small amount. Usually, I inject first 2.5 ml of foam, and I just have a look, and then if the filling and the spasm of the vein is not satisfactory, I inject another one. 2.5 ml syringe and so on, but most of the time you need 1 or 2 syringes to fill the vein. It's not necessary to inject large volumes. Most of the time people inject too much volumes.
And you don't compress the groin with the ultrasound transducer, eh? Claudine, you don't do that, no? No.
I don't do that. The answer is that I've shown that it is not useful, and even you can block for a large amount of foam, and if you remove the probe, you compress with the probe of the groin, and when you remove it, a large volume of foam is going to the
you have a bolus all of a sudden.
Like a bolus.
That's a bad maneuver, I think. We should not advise this to do this kind of maneuvers by compressing, because anyway the flow, the foam will always travel into the deep venous system, but it is not active anymore, as I just explained a few minutes ago, and it will always travel to the heart. If you do an echocardiography immediately after injection of foam, you can observe the bubbles in the right heart for sure. Yeah.
All right.
Are you
Anyway,
It's
injecting?
scary, but it is what it is
Yes.
happening all the time.
Yeah.
So I have a
And
question.
also
Linda.
you have many perforators everywhere. So if you block the groin, it's not enough. You have some foam in the deep end anyway. Yes, Marianne. But you should not be so scared about it.
Thank
But
you.
don't use too large volumes, of course.
So,
Linda,
yeah, I was going to just add something. I'd like to dial back to the actual, not to this question, but just prior to the comment from the case from Dr. Onita. So, but before I do that, I want to say one thing about the compression that we learned years ago, back in the late 80s. We were told to compress. We were taught to compress and keep compression with the liquid, the old liquid. But now with the advancement of foam, I guess it travels a lot more, but we were taught to compress and milk it down. But when we inject at the inguinal area, we usually begin a probe's breath away. Does that seem to be what you two physicians are doing as well, a probe's breath? And are you using long axis or short axis? I think it would be important for our listeners to know which technique you're using.
So we were used to have short cannulas and put them in place, flush with saline, and then inject. But I think, Claudine, you are using direct injection all the time, no? With a needle.
Yeah, correct. I use stage technique. First at the proximal part, about a 10 centimeter, I would say, from the groin. This is the first injection. Of course, if there is an actual reflux all along the saphenous vein, the great saphenous vein, so the first injection is done with a 2.5 ml syringe at about 10 centimeters of the groin, below the groin, and then we look at the distribution of the foam. Sometimes it's enough if the vein is not so big. If it is not sufficient, we do another one below this one, where the foam stops, and so on. Most of the time, we need 1, 2, or for big ones, we need 3 injections. So that means only 7.5 ml. And the mean, when we look at the studies, most of the time for great saphenous vein, we need about 4 ml only, 4 ml foam in the studies. So 4 ml is not so huge, and about 3 ml for small saphenous vein.
So there is also a possibility if you have a long track of great saphenous vein that is still, open. For instance, after previous high ligation, you may have a residual trunk, which is quite long, and you can use a technique which has been launched back in 2009 by Kurosh Parsi, which is called the catheter-directed foam sclerotherapy. We have also now added that to our new European Society of Vascular Surgery guidelines. So you introduce this long catheter. Originally, it was done with a thin bladder catheter, I think, if I remember well. And so then either with or without injection of perivenous tumescent solution, you can then also inject foam in quite large diameter veins, and this may work better than the usual foam according to the studies. But so far we have one meta-analysis and then one RCT, I think, small sized RCT. So the evidence is not that big. So in our guidelines, we have said that you may consider this technique, but it is of course not the first choice. The first choice would always be an endovenous thermal ablation if you have a residual trunk. So that's for sure.
So we do have a question from the audience. doctors, could you specify what type of foam you use? Each country seems to have different commercial products. What about physician compounded foam, other agents besides polydocanol? Do you make your own? Do you buy it? And if you make it, with what, and what's your technique?
Marianne?
Yeah, but I can get started if you want. So in Rotterdam, where we worked, we had no STD, so we had only polydocanol, and we made the foam ourselves. So we didn't have, we just made it with air, not with special O2, CO2 mixtures, whatever. So we prepared it on the spot and injected right away. So we didn't have any special pre-made foam, whatever. So it was just homemade foam, let's say. And we used, of course, the Tessari technique with the 2 syringes, or with the how do you call that? Stopcock, something like that. Yeah, three-way syringe. But Claudine?
We use most of the time we use polydocanol. We have both. We have also STD, tetradecyl sulfate de sodium, sodium tetradecyl sulfate. We have both and polydocanol, but in France we use polydocanol almost all the time. We mix 1 part of sclerosing agent plus 4 parts of air. This is room air, but we have, because of the French regulations, we have to filter the air with a special filter. And then we mix with a female-female connector, not 3-way stopcock. We use, most of the time we use a dedicated connector. And that's, we do, it's homemade also. We don't have Veritana in Europe. It is not, even in the UK. Do you know, Marianne? I think there is no.
Don't think so. No. No, it's not in Europe.
And I do the same as you all. I cannot get Varithena at my institution, and it's, it's easy enough to do it yourself. I just find that it comes out of solution very quickly, and so I usually need another set of hands to keep mixing. Any comments on what the endpoint should be? I still am one of those folks who's worried about the bubbles getting everywhere, but I'm hearing what you all say. I have fear of the bubbles. And so I will confess to everyone that I am one who has been compressing, but I will try not to after listening to you all to compress. But what are you looking for? What do you tell the patients the success rate is going to be with that? And then I want to move on after this question to another case. How do you follow these patients, and how often?
Can I jump in with one thing that I wanted to mention before, which may segue into this follow-up? I think the last case, or actually the first case from Dr. Oneida, I think that those extrafascial tributaries, short-term follow-up is very important after an intervention, because many times these varices, these extrafascial varices, will decompress or deflate, and they still have reflux, but they're deflated. So the patients think that their leg looks better, they're happy, maybe their symptoms have resolved, and they go on their way. But we document that because we have found, we were told in the beginning that only 10% would re-engorge. And now we're finding it's the opposite, 90% of them re-engorge.
Oh, wow.
So I think short-term follow-up is very important, as well as long-term follow-up, because we can possibly avoid recurrence, at least some of it, if we do a good investigation on the short-term follow-up. So I hope that helps segue.
I think especially if you have used foam, you have to do a follow-up either at, depending on your schedule, after 3-4 weeks, sometimes even 6 weeks, but I don't know which interval you are using, Claudine, but we saw the patient back like after 3 or 4 weeks after the foam injection. If we had an endovenous thermal ablation, then that would be 4 to 6 weeks. In our guidelines, now we have put that surveillance after whatever treatment is needed. I mean, is let's say recommended in 1 to 4 weeks after the procedure. But for foam, it is usually a treatment in different steps. So you always have a stage 2 and maybe stage 3 to treat the patient. So that's a kind of other strategy, let's say, than just a one-stop treatment. Foam is always, you always need to do follow-up and then maybe an additional injection, as you just pointed out. You agree, Claudine?
Yes, but not totally, because after foam, most of the time we have follow-up visit at 6 weeks. 6 weeks,
okay.
6 weeks, because if you want to do another sessions, if you do it too early, the inflammation could be too strong, because you don't wait enough between the two visits. And there's another reason for that. It's because the French drug agency in France recommend to see the patient not before 1 month, except of course if the patient has some symptoms before. But they ask us to make a control, to make the assessment at about 1 month or more.
Also after endovenous thermal ablation?
No, for foam. For thermal ablation, they ask us to make an assessment at about 10 days.
But that's probably more if you do a primary treatment, because then it's to check for potential e-hit or deep vein thrombosis. And if you have a recurrent case, the advantage of this neovascular bunch, if it has been surgery previously, is that usually if you do an endovenous thermal ablation, you don't get up completely to the saphenofemoral junction, so there is no issue about e-hit whatsoever. So that's a kind of advantage, a defense the patient has automatically.
Yeah, exactly. The health authorities have asked us to make assessment because of the risk of thrombosis. Of course, not. They don't care about the efficacy, in fact. So either for endothermal ablation for 10 days, or for thermal ablation or for foam, both recommendations are because of the risk of thrombosis.
Sure. So one last question about this and the use of foam is in some of these larger tributaries that do develop after, whether it's high ligation or endovenous ablation. Do you have much hemosiderin or staining of the skin following foam injection where the tributaries were after they deflate? Is that a problem in your patients who have lighter colored skin?
It's a problem if the tributary is close to the skin, of course. The hyperpigmentation will occur most of the time if the vein is large and very close to the skin. But even with thermal ablation, the risk is higher even for these techniques. It's because of the blood is trapped into the vein, and if it's very close to the skin, with the inflammation, you will have a high risk of pigmentation. Can you explain it better, Marianne? Maybe.
Yeah, I think these larger veins are often quite high in the thigh, in cases of recurrence from the groin. So patients don't really bother about a bit of pigmentation up there, usually, at least in our experience. Maybe the Dutch people are, not bothering about that too much. What we did is when there were really very large tributaries above the knee, sometimes, and I am a surgeon, I like to do phlebectomies, and it's easily done. So not really close to the saphenofemoral junction, but let's say big tributaries on the thigh, or if the anterior accessory is involved and there are really huge varicosities there, it's so easy to do phlebectomies, and the immediate cosmetic result will be better. Of course, with foam, you can do it easily, and Claudine can do that perfectly for sure. But so you have to tell your patient, it's all about communication with your patient. You have to tell your patient that there may be a transient pigmentation, but it always goes away, you have to be patient. So if you look at the patient 5 years later, you will never find that pigmentation back at the site of the sclerotherapy. Or am I not right, Claudine? A challenge after 5 years.
Well, I think you're right. I think it's it also depends on the age of the patient. And what I consider a young patient has gotten older over the years, because they very much care about that cosmetic appearance. I would like to, I appreciate all of your tips and expertise. I'm going to put a little twist on this patient, make it a younger patient. And this is from Dr. Oneida as well, who's gravida 2, para 2, so 2 children. She has vulvar and thigh varicose veins, medial thigh varicose veins on her left leg, and had a great saphenous vein endovenous ablation 3 years ago, so age 25, which very young for having that, but in any event, so has recurrent, and you could just imagine this person who comes in and they've got that little squiggly superficial tributary going all the way from their groin down to their knee.
And did she have the surgery, the laser before or after the pregnancies?
Dr. Oneida did not tell me that.
Okay, because if you have had already a treatment and then you have a pregnancy afterwards, the odds ratio to have recurrence, we have studied that in a large retrospective study years ago in more than 1,000 patients with recurrent varicose veins, and the odds ratio to have new recurrence, let's say, after a previous treatment is much higher if there is an interval pregnancy, as we call it.
So have a ablation, then have a pregnancy, and a much higher risk of recurrence.
Yeah,
okay.
It is. Yes.
Okay.
You also can have more neovascularization and more pronounced because a pregnancy is, of course, a moment that a woman creates blood vessels, because she's very angiogenetic, no, to have a placenta and so on. So this can be a stimulus for recurrence from the biological point of view.
All right. Linda, how would you approach this patient?
So these are always very challenging for the sonographers because they're looking at the saphenous compartment. Many of them don't think about the gonadal veins. But I learned, to always grab the vein light, just the ultrasound probe shouldn't be our only tool. That's how we are in our labs. So we grab the vein light and we will look and examine. But the first thing that would give it away is the patient's pregnancy. She's had 2 pregnancies and 2 births. So, when you see recurrence and you scan and you don't find anything in the saphenous compartment, which I think here you have nothing except vulvars on the medial aspect of the limb, you have to think that there was a secondary system, or, there may have been all along, or there is one now that has occurred. So then take out the vein light, you can try with your ultrasound probe to track it back. Many times you can if they're large enough, but when they're very tiny, I find it very helpful to use a vein light. But standing and bearing down with color and Valsalva can work beautifully.
All right, thank you. Any other approaches, Marianne or Claudine?
Well, what we also said in the guidelines now is that you should look for these typical pelvic escape points. You know, the gluteal, the obturator, the different typical escape points. You have to try to investigate them with the ultrasound. And of course, you may refer the patient also to transvaginal ultrasound. So ask a gynecologist to have a look at this patient. And with transvaginal ultrasonography, you can also see, you know, the veins going up. Of course, up to a kind of bunch of veins in the pelvis.
So this brings up an interesting point for me anyway. So how do you think it's essential to treat pelvic reflux if the patient is asymptomatic, or would you just treat the recurrence from the inguinal region down?
Yeah, that's absolutely an important point, and so you should distinguish between those patients who have pelvic symptoms like dyspareunia, pelvic pain, and so on, and those who have no pelvic symptoms. If they don't have pelvic symptoms and you just have varicose veins or recurrent varicose veins, whatever, then you can treat these varicose veins up to the escape points, and you don't need to treat as a first intention, let's say, the pelvic underlying pelvic incompetence, even if there is, because women who have had 2-3 pregnancies often do have lots of big veins around the uterus and so on, but without any symptoms. So no need to treat them. But if the patient also has pelvic symptoms, then of course you have to think about proceeding to an venography and then embolization at the same time. So that's you should clearly distinguish whether there are symptoms also at the level of the pelvis or not. And then, but if there are no symptoms, then just treat the veins of the leg in a first stage. And if that is not sufficient or they come back quickly, then you can you know, do additional diagnostic investigation and do the venography and potentially also embolization, but usually it's not necessary, because when treating, for instance, the escape points with foam, the foam already travels up in the pelvis and closes, you know, the escape points very, very well.
So Dr. Maeseneer would say treat the highest point of reflux, but you're saying if there's no pelvic symptoms, just treat the veins in the thigh that you see.
Yeah, that is based on the evidence. We have investigated that for our guidelines also, and we clearly distinguish these two. So it's always the principle: don't treat the ultrasound, treat the patient. Okay. And so you have to listen to the patient's complaints and then start from there. We don't think that all these women who have veins coming down from the pelvis after a couple of pregnancies need this additional embolization treatment. That's over-treating the patient, and you also have some risks. These coils may travel to the lungs. You know, you may have complications. So always think twice before, you know, doing the big stuff, and just start simply with what you can do, especially based on the symptoms of the patient. Of course, if you have a patient with chronic pelvic pain, with lots of complaints there, that's a completely different story. But that's only the case in about 10% of those presenting with veins, typically related to pelvic vein incompetence. So varicose veins are often in the 90% just presenting in the leg and giving symptoms there.
I think that's
So
excellent
it's really a
advice.
misunderstanding that that we have, and I am happy to disagree with Mark.
I agree with you, Marianne. Of
Yeah.
course, I totally agree with you. And there is no studies showing that you can improve the varicose vein of the leg when you embolize the pelvic varicose vein. So there is no interest to do
No.
it for the
No.
varicose veins of the legs.
Absolutely. They studied the outcome at the level of the legs after embolization, and okay, it may well be a nice radiologic picture at the level of the pelvis, and it may be very beautiful for the the radiologist or whoever did it, but the veins have not changed for the patient, and so you have to then do that in a second stage. We in the guidelines now advise to listen carefully, and if there are no complaints, then just get started with the most simple approach, which is try to occlude the pelvic escape points and treat the varicose veins coming down, and very often with foam, because that's the best approach for that.
That's awesome. Thank you all very much. That's great advice. At what point would you subject a patient to, say, more advanced imaging? So say MR venogram or a CT venogram? Would it be only if they then have pelvic symptoms, or are you trying to, you can't find the pelvic escape points? We don't have, as I've stated, I'm doing my own ultrasounds because I don't have a tech. So at what point would you send someone for imaging?
I think that you have to send a patient for imaging of the gonadal veins. That's as I just explained, based on the symptoms. But you may also have patients who have varicose veins coming down from the pelvis, let's say, which are based on, for instance, common iliac vein compression syndrome, which we previously called the May-Turner syndrome, or you even may have patients with left renal vein compression, which we previously called the Nutcracker syndrome. So if you think about this kind of diagnosis, or you suspect a post-thrombotic problem above the inguinal ligament, and this you may suspect, for instance, when you do the ultrasound in the supine position, and there is a very good phasic flow at one side, so we're going up and down with the respiration, and at the other side there is no phasic flow at all, so there is no respiratory variation, then you have to make sure that there is no problem of obstruction higher up. And so then these CT scan, MRV, and so on come on the scene, because these patients should be evaluated in particular if they have lots of symptoms. So that's not just for varicose veins usually, but then we speak about patients who have more advanced disease, C4, C6, according to the CIP classification, especially those with a recalcitrant ulcer. And then you are in another kind of patients than we were just discussing right now with the examples. But in those cases, are patients with venous claudication, all this has to ring a bell that you have to investigate above the inguinal ligament. And then these patients need to have a MRV or a CTV, whatever, what is available in your center or in your neighborhood.
Thank you. Any other thoughts on that, Claudine?
No, I totally agree again. Once again with Marianne. What Marianne is? That's okay.
We have been working closely together, so we tend to agree on many points, isn't it?
And Linda, when would you advise someone like myself to throw in the towel with the ultrasound and order some type of scan?
Yeah, any kind of unusual finding that you can't explain in your lower extremity, especially when you're in the common femoral area, not just lack of phasicity from one side to the other, but even some dissymmetry. I would really carefully assess those common femoral veins. But I would like to add one other question, sort of question. Would you consider treating the patient who has had recanalization twice in the small saphenous vein and you, with a history of hemorrhoids? What would you consider your next step in a patient that has had recanalization in the small saphenous vein twice and you're suspecting it's coming from hemorrhoidal veins?
It's a very rare case, I think.
We did have it in New York.
It is probably a case report for sure, and you may have these patients who have, for instance, the veins coming down along the sciatic nerve. This can be an issue. These are the more exceptional cases, and of course it can be difficult, first of all, to understand what is going on, and then second, to do the right treatment. So if this has been a thermal ablation of the small saphenous vein with recanalization, then I would wonder if you have used the right technique, the proper, energy, and so on. Maybe I have to admit, I have had once a vein that didn't want to close with thermal ablation, even with high level of energy. And that was because of the fact that the vein was really very thickened and full of collagen. So there was a narrow lumen. I managed to make my way through and to do the ablation, but apparently the amount of joules was not high enough. And eventually I ended up doing a high ligation and excited a part of that vein, of that great saphenous vein. It was a small saphenous vein, it was a great saphenous vein. And I sent it to the histology, to the lab. And when we did sections of that vein, it was completely filled with collagen. So it was very, very fibrotic. So it hadn't reacted to the thermal energy as it was expected to be. And I decided in agreement with the agreement of the patient, so to do this operation. It had been since years I hadn't done high ligations anymore, but I did that in that case. And it was very funny because you could roll the great saphenous vein. You could roll it. It was like a tube, a rubber tube, It was a very funny vein, and you couldn't squeeze it. It was just a solid tube, and so but it had recanalized, and it hadn't answered properly to my thermal ablation. So I understood why, because there was lots of collagen. But that, but for your case of the small saphenous vein, it's very. Was it the thermal ablation that had been done?
Thermal ablation ×2.
Yeah.
It's really strange. I've never met this kind of cases. Small saphenous vein recanalized twice after thermal ablation. It's very strange.
Yeah, it's very exceptional, I think. But the thing is, of course, when we look at the studies, the occlusion rate is very high for thermal ablation. It's more than 90%, 92, 93%. Even some studies end up almost 100%. But if it's 92%, let's say, then there are always some that don't close, of course. So yes, that's but it is often that is what I wanted to explain with my example. Often it is because of the fact that the vein wall is abnormally thickened, and the composition of the vein wall is not normal. It's not just the intima media adventitia with the usual tissue, but there is lots of collagen. And so lots of fibrosis, and this reacts more difficultly to whatever ablation you would want to do, but also to thermal ablation in the end. And these are the veins that don't answer to your proper treatment. But
and the channel was very narrow in this case, Marianne. So
yes, absolutely, yeah.
So ladies, we are about out of time. This has been a wonderful discussion. Linda, I would tell your person that the saphenous vein is not related to the hemorrhoids. They just happen to occur at the same time, because I don't want a bunch of hemorrhoids to get referred to me for treatment. But I'd like to thank.
There are other specialists for that.
Yes, absolutely, absolutely.
Yeah.
So I'd like to thank Linda Antonucci, Marianne de Maeseneer, and Claudine Desnos as our experts today. It has been a fascinating discussion. I'd like to thank our sponsors again, Boston Scientific and Medtronic, for their generous support of EmPowHER, and as well as Vein and Lymphatic University. I'll give a plug for our next webinar, which will be on Saturday, February 5th, and the topic to be announced. So be looking for a flyer on your social media. So with that, folks, enjoy the rest of your Saturday. Thank you all who have been in attendance on Facebook and on Zoom, and have a great rest of the day.
Thank you.
Thank you.
Thanks
Bye-bye.
for the invitation.
Bye.
Thanks for having us.
Bye-bye.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.